Please note that the opinions and ideas shared on this podcast are those of the speakers, not the opinions of the Ogden Surgical Medical Society or its board. While medical topics will be discussed, it is not to be taken as strict medical advice, and individual clinical judgment is warranted in applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed with regards to their medical practice. Welcome, everybody, to the Ogden Surgical Medical Society podcast. We're really happy to have you back, and we think we have a great podcast opportunity for you to listen to today. I'm Clark Madsen. I'm a sports medicine physician here in Ogden, Utah, and I'm one of the hosts of this podcast. And I'm joined today by Dr. Stephen Sharman, my co-host, who can introduce himself.
Yeah, I'm Steve Sharman. I'm also work alongside Dr. Madsen at McKD with the Family Medicine Residency Program.
We are really excited today because we get a lot of great speakers on this podcast, but I'm especially excited to talk with Dr. Karsy today. It's been fun looking through his bio, getting to know more about him. And I think Dr. Sharman and I both have been talking the last few days about questions and things we want to discuss with Dr. Karsy. So Dr. Karsy received his undergraduate degree in neuroscience from UCLA and his MD PhD from the New York Medical School. He is Master of Science in Bioengineering at the University of Utah. That's also where I got my undergrad degree in bioengineering at the University of Utah. So already I like him. Medical residency at the University of Utah and a fellowship in minimally invasive and open skull-based surgery at Thomas Jefferson University Hospital in Philadelphia. His research is focused on translational neuro-oncology and targeted therapy, prognostic markers, and novel surgical techniques. Besides many academic and research positions, he also volunteers with the UCLA mentorship program and belongs to many medical societies, has several patents, and leads a lot of neurosurgical training courses. He lectures extensively and has written many journal articles. His CV is practically a book in of itself. And he's even co-authored the surgical handbook. So we were really lucky to have Dr. Karsy lecture on our updates in neuro-oncology and skull-based surgery previously. And he has been a staff neurosurgeon at the George Wallen VA Medical Center and Davis Hospital and Medical Center. We are also happy to report that he's now working at the Global Neurosciences Institute in Philadelphia as the Director of Minimally Invasive and Open Skull-Based Surgery and the Director of Minimally Invasive and Complex Spine at the Drexel University College of Medicine in Philadelphia as Assistant Professor of Neurosurgery. So after all of that, we are very excited to be able to talk today about traumatic brain injuries and spinal cord injuries and how that can affect the physician population at large. So thank you so much for being here.
Dr. Madsen, Dr. Sharman, thank you so much for the opportunity to come and speak with you guys and just to have a conversation about this. You know, we were talking about different topics to discuss, and I thought traumatic brain and spinal cord injury were things that would be interesting, especially to the primary care population and patients, because these are very, very common things. You know, Utah is a huge sports community. They're common things that you see with just everyday activity. So I thought it'd be something very interesting to talk about. Thank you for having me.
Yeah, I think we agree. I think around here, unfortunately, traumatic brain injuries aren't all that uncommon with all the opportunities to go outside and hurt yourself. Some people figure out ways to do it creatively and unfortunately can suffer some long-term effects from that. So this is a topic I think most of our listeners are going to want to really listen closely to.
So, Dr. Karsy, I thought I'd lead off with a question that was pertinent recently for us. Dr. Madsen and I and some of the other primary care physicians cover one of the local ski resort medical clinics. And unfortunately, I was working on the day when we encountered a snowboarder who had suffered a C-spine injury and was found initially to have no motion or sensation below the waist, a little bit of posturing of his upper extremities. And he was ambulanced off to our hospital here at McKD and ultimately underwent surgery for a decompression of the spinal cord after a diagnosis of a C5 burst fracture with instability. So the questions that came up for us, or for me in particular, was, we've heard in the past treatments acutely that might change outcomes or benefit outcomes, such as high dose steroids and corporal cooling, as well as some transfer to facilities that do this all the time. And is that something that would have been preferred? So I just thought I'd get your thoughts on that, of how we would deal, what your recommendations would be, and what's the latest on that type of an injury.
Yeah, it's a great question. With spinal cord and also very much traumatic brain injury, and you think of it as broken up into primary and secondary injury patterns. So primary injuries really include the trauma, the force of the trauma with bone, disc, or ligamentous impaction or hemorrhage impaction on the cord. And secondary sort of injury occurs afterwards, where you have hypoxic injury, inflammatory injury, gliosis. Those are sort of the things that happen afterwards. The primary injury, the goals of treatment are essentially stabilization and decompression of the spine. So I think the earlier you do this, the better the outcome. There's certainly a study published, as a big Canadian multi-center study called the STASCUS trial, which talked about whether there was any improvement in neurological outcome with early decompressive surgery, and early being defined as less than 24 hours versus greater than 24 hours. And this was from 2002 to 2009. There's 6 centers that did this, and it's published in 2012. And basically, they showed that if you decompressed patients or stabilized them within 24 hours, you had basically doubled rate of improvement of your AIS grade of 2 points, 2 levels at least 6 months. So there was a statistical and clinically relevant improvement in outcome with early decompression and stabilization. And so the argument of where is the best place for a patient obviously is going to be kind of where can you get definitive decompression and stabilization as soon as possible. And to your other point, the secondary injury is kind of what we want to protect against and prevent, after the primary injury, after the stabilization. And with spinal cord injury, unfortunately, there are not a lot of great treatment options that exist. I think augmentation of mean arterial pressure greater than 85 millimeters of mercury seems to be a pretty common thing that's done, with very little evidence of benefit. Unfortunately, we don't have randomized trials that support this. We have a lot of sort of level 2 and 3 data kind of supporting that maneuver. And the timing of how long you can keep these mean arterial pressures elevated is controversial as well. 3 to 7 days. Surveys of different neurosurgeons and spine surgeons get all sorts of different answers. So we can't even agree on the timing of it necessarily. A lot of the other treatment options that you talked about, high dose methylprednisolone through the NAST trials, NAST trials, they were essentially not, in my opinion, they were not helpful. What happened with the original trials was that there are 3 different trials that were done. They were looking at whether high-dose methylprednisolone compared to other treatment options had an impact, and it really didn't on the primary outcomes. It was only when you went back to secondary analysis and looking at secondary outcomes did you see that early administration of high-dose methylprednisolone had an improvement in patients treated earlier. So it was really this sort of secondary, underpowered, analysis that was not the primary study, the direction those studies were looking at. So I think the data to support high-dose steroids is very limited. I think in many different communities, people use it because if you have a young patient with a devastating spinal cord injury, you can pull out all the stops. You try to do what you can for them. You hope that they can tolerate the side effects a lot better. And there were definite increased risks of GI bleeding and wound problems with patients who are on high-dose steroids. Maybe young patients tolerate it better. In some other communities, I'm currently on the East Coast, and there's a very strong medical legal community here. And so use of high-dose steroids is oftentimes used here for medical legal reasons rather than anything that necessarily helps the patient, or at least the data doesn't support it. So in my mind, the best treatment for a patient really is stabilization and supporting, which most ICUs, I think, can do. We did a study in 2019 that was looking at the outcomes of patient recovery after spinal cord injury. And we specifically looked at patients that were directly admitted to a specific hospital versus being transferred. And we assume that patients that were transferred, oftentimes being transferred from community hospital settings or level 3 trauma settings to maybe a tertiary care facility or center of excellence or some just higher level of care. You're not going to transfer a patient if you can manage them most of the time. I know pandemic kind of threw everything in a whirlwind, but for the most part, I think if you keep a patient, you believe that you can treat them as good as possible. What we found was that directly admitted patients often had shorter lengths of stay by about a day. They had lower charges, but they did have sort of worse survival as well. In our mind, that basically means that the regional hospitals that are there can essentially do a good job in treating these patients. And I think that the treatments that exist for spinal cord injury in terms of stabilization that any good spine surgeon can do, as well as arterial blood pressure augmentation that many good intensivists can take care of, I think those can be done in community hospital settings. And the polytrauma and the sort of more acute, patients, those might be the patients that end up needing to go to the tertiary care centers, and they have kind of the higher mortality. So those are, in my mind, how patients can potentially be treated with different injury patterns.
Yeah, I think that's really interesting, and I really love the kind of the data-driven approach you're taking to this here, and it got me thinking. Not to get us too far off topic, but reading through, I saw kind of a lot of the research that you've done in this population of acute spinal traumas, head traumas, and kind of as a fellow researchers, I just thinking how hard it would be to find a few patients to enroll in a trial like this, let alone the 50,000 that you had in that study. As a researcher, what kind of struggles or successes have you found in recruiting people right in some of the worst moments of their life, and how do you approach that?
Yeah, it's a great question. I'll tell you, I guess, a success story and kind of a not so successful story for trials that I've been involved with. One of which was it was actually in relation to spinal cord injury, is a company that was looking at basically a anti-gliotic kind of anti-inflammatory compound, looking at high-level cervical injuries, ASIA A's and B's, with very, very strict criteria of patients that had injury at C4, C5, C6 that you were going to do surgery on and inject this compound versus a placebo. It's a very, very stringent trial. It sounds fantastic. They had done numbers looking at how many patients we'd be able to potentially recruit in Utah and other places. And nothing happened with the trial. It was so stringent. We don't have any treatments for spinal cord injury, but yet again, the trial, you couldn't recruit the right patients for. It was just too stringent, too difficult to do. It never got off the ground. So a different trial that this is sort of one of our success stories, even though the outcome was negative, is one clinical trial we did at the University of Utah. And I did this as a resident. We were looking at the role of vitamin D supplementation for patients in neurocritical care settings. So these are not just traumatic brain injury or spinal cord injury, but they included aneurysms and patients with tumors and anybody that came in emergently through the ER for various reasons who had a low vitamin D level. We randomized them to receive vitamin D supplementation and replenish them back to normal within a day versus placebo. And it's like a perfect study for resident, like super safe drug, no toxicity, very easy kind of data and safety monitor reviewing. And most patients, believe it or not, when you start to explain like, hey, there's data to support that this could work, the harm is none, minimal to none. I mean, we check electrolytes and have intensivists in the ICU checking these patients, so they screened out anyone that was going to be harmed. I mean, almost everybody signed up for this thing. We were able to recruit it and finish, I think it's I remember the exact number of patients, something like 250 patients in about a year and a half, and got it done. And unfortunately, the study result was that vitamin D supplementation didn't improve outcomes in these patients, but it was something that we could achieve. And I think that, for you, Dr. Madsen, is interested in research and wants to do this, and you're like, man, I can't see myself doing a clinical trial. I'm just a community doc I can't do clinical trials. That's not the case at all. That you're in this perfect environment to see directly what impacts your patients. and understand the resources that are accessible to patients. Not everybody gets to go to an academic tertiary care center, and believe it or not all the care is any different in that center than a community hospital. And so I think we have to get away from this dichotomy of tertiary and community centers, and instead think of, well, we're all doing medicine, we're all trying to treat patients the best way. If there's a treatment that works at one place, why wouldn't we use it somewhere else? We don't have infinite capacity at tertiary care centers to transfer every spinal cord and traumatic brain injury patient to those areas. So how do we figure out who's the right patient to send to those specific areas, either for clinical trials or maybe because there's some specific treatment that exists that doesn't exist somewhere else yet? So I think those are the questions we should be asking, instead of whether research can only be done in an academic center, which I don't believe that's true at all.
Yeah, I think I would agree with you on that one.
Speaking of research or lack thereof, one of the other things that comes up a lot, at least in the lay press for spinal cord injuries, is stem cells as kind of the future. Is that true, or is it another one of these things that probably won't be studied very well because it's so difficult?
It's difficult to study. It's a great question. The data is great. It's promising, right? That stem cells can regenerate the spinal cord. We have tons of animal data that suggests it's important. It's impactful. Very limited clinical data in humans show that it's helpful. There's some idea that maybe these stem cells secrete growth factors, neurological growth factors that help improve nerve regeneration or at least signal conduction. I don't think it's ready for prime time. It's sort of promising, but not yet there. One of the things that I find a little bit closer to prime time that I'm waiting to see the right studies be done for this and be able to turn it into an applicable therapy is spinal cord stimulation technology. Basically, electrodes or paddles that you can place at sites of injury that you can stimulate, and through really unclear and unknown mechanisms, allow patients with high levels of spinal cord injury to recover some function. Maybe not the ability to completely walk, but maybe an ability to stand and bear weight, take pressure off of pressure points that reduce risk of decubitus ulcers, whatnot. There's research by the name of Reggie Ederton at UCLA that has done a lot of animal and human proof of concept spinal cord stimulator trials. And I've had a chance to meet him and sort of talk to him about some of his research, and it's been really interesting. Patients that are ASIA A, basically means no motor sensory function below a level of injury, can't stand or walk, have these spinal cord stimulators placed, and then after a period of intense rehabilitation can at least bear weight or maybe even take steps. So I've seen it. I've seen the video. It's hard to believe, but I've not seen any video like that from stem cell treatment or anything else. And the beauty with spinal cord stimulators is that they exist. They are already being used thousands of times a year for chronic back pain and failed back syndrome. So they're technology that's been proven to be safe and exists. And so that, I think, is a closer technology treatment that could be used for patients with disability after spinal cord injury that needs a lot more work.
So short of these things that are available in specialized centers that may be our future, for patients that have severe traumatic brain injury or spinal cord injuries with that upper level grade A and B that you mentioned, is there any hope for improvement in them?
It's a great question. It's a very common question we get inpatient when patients are coming in with high level of injury, especially if they're young, and they're thinking about what their future life looks like. The most recent studies, there's a recent review that came out looking at all the literature on recovery rates after ASIA A and B. It basically broke down the data by all the different classifications and essentially showed with patients who have an ASIA A level of injury, these are the most common types of injury. About 30 to 60% of patients have an ASIA A type injury. They're bimodal. You have young patients with trauma, motor vehicle collisions, sports, assaults as the reasons for these in one group. And you also have elderly patients. As the population is getting older, patients come in with falls. And so they can get spinal cord injury from falls alone. And so you have two groups of patients that are coming in with this pattern. With ASIA A type injuries, about 20 to 30% of patients will show improvement. About half will go to ASIA B, which means they regain some sensory function, no motor function, or ASIA C, where you at least gain, strength less than 3 out of 5 in terms of strength at some level of injury. So those can mean the difference between someone being completely bedbound to being able to potentially have some sensation or power of motorized chair or use a mouse to access the internet to talk to their loved ones. So whenever we do see these patients, I try to encourage them and say, look, there's this period of time that it takes for things to recover. So you have to be very patient and participate in rehab. The best recovery after spinal cord injury, the literature suggests, is between 6 to 9 months and really doesn't improve much more after 12 months. So that's a very, very long time course compared to a patient you see as an inpatient, and you do have to kind of educate them and encourage the family that there's some room for improvement. And I'd say above anything else that specialized neurorehabilitation probably is a thing that's the best for, if we're going to refer patients from the community to some center, that seems to be the place that probably has some benefit, right? It doesn't mean that patient has to go there and live out 6 months of rehabilitation. Maybe it means they spend 1 or 2 weeks and then they can follow up as an outpatient or telemedicine liaison with their community physicians. But that probably has the better bang for the buck than the high level ICU care that really can be done kind of in many, many kind of community settings.
So is that potential for improvement age related?
Very much so, yeah. So the factors that these studies kind of discuss are age related. Gender seems like females seem to do better with recovery. We don't know why, or if it's a hormonal reason, or if it's just the data is panning out that way, or they don't have a high level of injury. Patients with tetraplegia seem to do better. So there are these potential sort of factors that suggest risk improvement, but it's still a little bit murky, I'd say.
Yeah, so a lot of times, many of the doctors that listen are not necessarily going to be there in the inpatient setting, having kind of these immediate conversation with the patients, but these patients with these long-term head or spinal cord injuries are still going to be seen out in the community. They're still going to need nephrologists. They're still going to need OBGYNs and primary care doctors. What sort of things should kind of the average average physician who's seeing these patients be on the lookout for or kind of pay close attention to?
Yeah, it's a great question. With traumatic brain injury, it's something that basically has a high prevalence. There are a lot of patients that are in the U.S. with traumatic brain injury that are living and trying to work and go to school. Same sort of bimodal distribution is happening with falls and versus motor vehicle collisions and assault. The data seems to suggest that patients that have moderate to severe traumatic brain injury, so you were talking about patients who've been temporarily in comas and then recover, these patients are about two times more likely to pass away about 3.5 years from injury. So they have a higher mortality and morbidity even after they recover from the injury. And the primary care physicians are the front line of these patients. They're going to be coming in and have problems with work, school, learning, memory, emotional dysregulation. They have difficulty with sleeping. They have higher rates of depression, anxiety. You can have post-traumatic epilepsy. There's about a 7% chance of early epilepsy in patients, which can persist throughout their life, even after you treat temporarily with anti-seizure medications. And epilepsy is disabling. You can't drive if you're having seizures. It's hard to hold jobs. It's hard to have conversations. So these are going to be the things that the primary care physicians see first line. In the elderly populations, there's data that suggests that they have increased risk of neurodegenerative disorders and dementias after head trauma as well. So what I think primary care physician can do, at least with TBI, is recognize that there are these symptoms that can exist that may be related to prior TBI or recent TBI, and then find the appropriate referral for them. So there's a very good traumatic brain injury rehabilitation program at the University of Utah. There's other regional rehabilitation centers that exist in Utah as well that are exceptional. there are neuropsychiatrists and geriatricians that can help with screening for dementias and put patients on appropriate medications, as well as put patients on medications for depression, anxiety. Many times the primary care physicians can start the medications for depression, anxiety, and if they feel comfortable, even neurostimulants, dopamine agonists for attention. So those are things that can be done. You very much can have an impact in these patients' lives. And with spinal cord injury, there's higher rates of spasticity after spinal cord injury. Those are sort of the chronic problems that come with it. Urinary retention, you mentioned, was one, but spasticity exists as well. I found when I've talked to our nursing staff and I've tried to educate them, I point them out to the Christopher Reeves Foundation. They have incredible resources on sort of what to expect, what are appropriate things to anticipate. It talks about non-dysreflexia and like what to look for and how to prevent it. And so there are great resources that exist that the primary care physicians can point the patients to, and they can also point patients to the appropriate rehabilitation physicians to help with baclofen pump trials and Botox injections for spasticity. There's selective neurectomies that you can do. One of my partners at the University of Utah, Dr. Mark Mahan, does selective neurectomies for patients with stroke or spinal cord injury. And so instead of, if you have a patient with very focal spasticity, an arm or a leg or one side, if they're hemiplegic, hemispastic, you can essentially do selective neurectomies of partial nerve rootlets going to the muscles and help with reducing the spasticity while still maintaining some tone and function. So there are some really, really incredible technologies and treatments that exist. And I think recognition is probably the first thing. I'm hoping the podcast helps with that, and to whatever extent I can help with, and then just finding the right people. It's very much a team approach to treating these patients. No one has to do it alone. There's a good team of people doing this.
Well, as a sports physician, we oftentimes are caring for milder traumatic brain injuries, more on the concussion side, and sometimes those symptoms will last for quite a bit longer than the patients would prefer. And I've always found that, more and more I'm treating them with cognitive behavioral therapy principles and psychiatricals more than anything to just make their symptoms go away. So I think that kind of goes along with what you were saying there.
I think something just to reassure the patient that these are normal symptoms, and many times they get better with mild concussions, mild TBI. That's enough for a lot of patients, and it does help them very much so.
So in the end, kind of our last few minutes here, in your view, kind of, do you see anything on the horizon? You mentioned the stimulators. You see anything on the horizon that we should be excited for in the next decade or so?
Traumatic brain injury and even the spinal cord injury, I think the neuromodulation seems to be one of the more exciting fields. Stem cells and I think the biological treatments are exciting as well, but I feel like we've really tried a lot of them. We've tried stem cells in animals, TBI models, spinal cord injury models. None of them exist clinically. Neuromodulation exists clinically. It's used every day for treatment of Parkinson's disease, essential tremor, as well as now anxiety and OCD. So there have been studies. We talked about the spinal cord stimulators for improving recovery after spinal cord injury with mechanisms we don't understand. And there was a recent study that was published, I think it was in New England Journal, talking about reticular activating system stimulation on patients that were basically in very, very deep comas. And it showed that there was an ability to improve arousability and alertness in patients. So is this a potential treatment for patients in coma? I mean, why not? Things that were in Star Trek that were science fiction are reality now. So there's always a possibility. We have a technology that we're using that's clinically approved, that is safe, and we have potential better understanding of where these different circuits and where the connectomics of the brain connect that you could potentially intervene on. I don't think it's too far off to believe that there could be a way of activating different parts of the brain or disabling different parts of the brain to help with recovery. And those are closer to clinical use, I think, than many other types of technologies, just because of the technology and engineering.
That's really exciting, and I think we definitely have some amazing things hopefully coming down the road that we'll be able to ask you about in a future podcast. Before we finish, we always like to end by kind of asking something on more of a personal note, and one to see. We're kind of in the middle of the winter here, but is there any upcoming travels or exciting trips that you have planned with either yourself or your family?
Well, I guess the exciting thing for me in springtime will be to travel to California to visit family. That's kind of our next trip. So that'll be something to look forward to. The warm weather in Southern California will be always something to look forward to.
That'll be nice coming from Philly and
Oh,
a
yeah.
little warmer. So, well, wonderful. Thank you again so much for meeting with us and talking with us again. I think I've learned a lot, and I'm hopeful that our listeners will learn a lot and ask a lot of questions that we will reach out to you if we get some good ones and find out.
No, I'd be happy to chat more. I mean, thank you guys for having me. You guys are doing incredible work. Keep it up. This is great.